Hi, my name is Nicole Sisko, and I'm an upper division student in the Sports Medicine and Fitness Technology program at Kaiser University, Melbourne campus. Today, I'm going to be talking to you about hamstring strain. So before we talk about the injury and the anatomy, what is a hamstring strain? It's going to be a tearing or straining of the muscle, and it's most commonly seen in the long head of the biceps femoris. So now we'll get into the anatomy of the hamstrings. Hamstrings are composed of three muscles: the biceps femoris, which has a long head and a short head. The long head is in the left picture, the short head is in the right. Next we'll view the others. The long head of the biceps femoris originates at the ischial tuberosity and inserts on the lateral condyle of the tibia, head of the fibula. The short head originates on the lower half of the linea aspera and lateral condyloid ridge. The biceps femoris is responsible for external rotation of the hip, external rotation of the knee, as well as hip extension and knee flexion. So the next muscle is called the semitendinosus, and this muscle originates also at the ischial tuberosity and inserts at the anterior medial surface of the tibia, just below the condyle. The semitendinosus is responsible for hip extension, knee flexion, internal rotation of the knee, as well as internal rotation of the hip. The third muscle, is the semimembranosus. It also originates on the ischial tuberosity and inserts on the posterior-medial surface of the medial tibial condyle. The semimembranosus is responsible for hip extension, knee flexion, internal rotation of the knee, and internal rotation of the hip. So now we're going to talk about the mechanism of injury. How does this injury usually occur? So it's found that it occurs mostly in athletes who play sports that require brisk accelerations of speed and cutting, like football, soccer, and even tennis. And it most commonly originates at the proximal myotendinous junction at the ischial tuberosity. So now we're going to talk about some signs and symptoms. The athlete may hear or feel a pop in the area followed by immediate pain. They may also experience altered stride length. A mass may appear and is usually palpable at the site of injury. Bruising or discoloration may show itself, but what you want to do is also ask the athlete questions pertaining to the injury, as well as a physical examination. So now we're going to talk about evaluation of the injury. And research done by Mark Sherry on the examination and treatment of hamstring-related injuries shows that the slump test should be performed to rule out neural injury. Again, talk with your athlete for the details of when the injury occurred. Next, you're going to perform another physical examination, and often there's an area of point tenderness or a palpable fascial defect. MRI may be used to detect if a complete tear is present. So now we're going to talk about acute treatment. Research done by J. Peterson and P. Holmich show that treatment for hamstring strain should be done in phases. So the first phase for treatment is going to follow the Price protocol of protection, rest, ice, compression, and elevation, with a main goal of reducing swelling, bleeding, and pain. NSAIDs may be helpful with inflammation at this stage. The second phase occurs between the 7th or 8th day after the injury. Electrical stimulation may be used, as well as passive range of motion, myofascial release, and isometric exercises may be introduced at this point. The third phase for acute treatment is known as the remodeling phase, and it occurs 1 to 6 weeks after the initial injury. The athlete can incorporate stretching, strengthening, as well as partner-assisted stretching, if that's more comfortable for them. The fourth phase can include sport-specific activity, as well as increasing strength. Now, bracing or taping would not be utilized for this type of injury. Next, we're going to talk about rehabilitation for the hamstring strain. Research done by Lauren Erickson and Mark Sherry found that rehabilitation should also be done in phases. The focus of phase 1 is going to be minimizing pain and edema, restoration of normal neuromuscular control at slower speeds, and the prevention of excessive scar tissue formation while protecting the healing fibers from excessive lengthening. So you don't want to do any further damage while you're trying to rehab the injury. Phase 2 focus allows for greater intensity of exercise, neuromuscular training at faster speeds with the initiation of eccentric resistance training. Phase 3 progresses to higher speed neuromuscular training and eccentric resistance training in a lengthened position in preparation for the athlete to return to sport. And exercises should be progressed based on the athlete's tolerance, and progression should be limited if the athlete reports pain, increased stiffness, or anxiety with the movement. This is the picture of the proximal joint that usually occurs with the strain. Okay. So now we're going to talk about prevention. First we're going to talk about return to play. Again, I have research done by Lauren Erickson and Mark Sherry that found when athletes return to play, a clinical examination of the injured leg should reveal no signs of remaining injury. There should also be no pain on palpation of the injured muscle. Isokinetic strength testing should be performed under both concentric and eccentric conditions. There was another study done by Delvaux and colleagues, which found that muscle strength performance was the second most common criteria for return to sport. The active hamstring test should also be utilized. If insecurity is reported with that test, it is recommended to wait an additional 1 to 2 weeks before retaking the test. An athlete's ability to return to sport may also be predicted by certain functional testing, such as the ability to perform a single leg hamstring bridge. And finally, we're going to talk about prevention, the utilization of appropriate training to strengthen the hamstrings. Research done by Verall and Barnes show that when developing a program to prevent injury, an intervention program should be based on increased high-intensity, interval, anaerobic training that more accurately reflects playing conditions of the athlete's sport. It should also incorporate stretching while the muscle is fatigued and implementing sport-specific drills, which have been shown to significantly reduce the number of injuries. And I'm going to include my references, and thank you for watching.